Hello and welcome to the Best of EASD 2025 series hosted by the EASD Early Career Academy. My name is Eva Brum. I am a research and teaching fellow at the University of Geneva and a member of the EASD ECA committee. In this series, young researchers and clinicians from across Europe share their personal highlight from this year's EASD annual meeting. Today, we are joined by Marlies Eichner, medical doctor at the Hietzing Hospital, who will introduce her highlight. Dual glucose ketone sensing, how close are we to fully closed loop and continuous glucose monitoring during diabetes ketoacidosis? Marlies, the stage is yours.
Thank you very much for the introduction. Hello. Hello, my name is Marlies Eichner, endocrinologist at Hietzing Hospital in Vienna. There we have one of the largest insulin pump outpatient clinic in Austria. And therefore, my focus today is certainly on type 1 diabetes and technology. I would like to thank the EASD for the opportunity to share a few personal highlights from the Congress. So here you can see a little bit about me. And here are impressions of the Congress. And here is my first highlight. I will start with the APOD session with the ketone glucose sensing. I joined two different sessions about it. Technology is on the way. There is currently a consensus document on the way, which was written by people all over the world on how we should use this technology in the future. So what can we see is that DKA is not uncommon and very expensive. Prevalence of DKA at diagnosis is increasing up to 2% annually. And so we need something to do it the other way around. In the semi-quantitative urine testing, the level of ketones can only be estimated. Capillary testing is already far more than and accurate, but regardless of the type of the test, it must be performed when necessary. And that's the crux of the matter. As you can see, many individuals living with diabetes have suboptimal engagement with ketone monitoring. So you can see 65% do not test at all. The new dual sensor, which measures glucose and ketones, should shift this paradigm. Passive data collection, no second advice needed. You have alarms and trend arrows. So I hope this will help prevent people for ketone acidosis. The new dual sensor is important for people who need insulin, for example, type 1 diabetes patient, and especially when there is a SGLT2 inhibitor on board. For me, it was very interesting that you can see that CKD does not increase the risk of DKA. So you can see at the right side, which increase the risk for DKA is type 1 diabetes, for example, or frequent very high glucose levels. Also, women are more often with DKA than men. So this is, for me, it was a new thing. So perhaps in the future, AGP will look like this, with additional sample system for ketone levels. In the future, the plan is to connect these dual measurement systems with automated insulin delivery systems to optimize treatment. It remains to be exciting. So the next topic was this one, how close are we to fully closed loop? Here, Professor Moshe Philipp presented the consensus recommendation for the use of automated insulin delivery systems. And we can see the increase of time in range and decrease in HbA1c with either no change in time below range. With the optimal settings with the glucose target 100 milligram per deciliter and active insulin time for 2 hours, The goal time and range was above 70%, could be achieved in various countries, as you can see here. So IDA systems should be the preferred insulin delivery method. And he showed us things up for the future. Different kinds of AD systems were represented that are currently being researched, like neural net, artificial pancreas, or the B hormone, multi-hormone glucose loop systems, or also the AA augmented AD systems. The next thing I would talk about is the next AD system during pregnancy. There are no head-to-head studies already, but a comparison of these systems and the outcomes. Professor Katrien Ben Halima from the University in Leuven, it's in Belgium, showed us different hybrid closed loop systems with their benefits, but also with their challenges. As you can see, we have here the Minimit 780G, the Omnipod 5, the Control IQ, and also came APS-FX. Here you can see the different kinds of AD systems which are commercially available and how to use them, where you can change settings. Unfortunately, in Austria, we only have two of these systems. We only have the Minimate 780G and the CAM-APS FX already. We hope that next year we become a few more options for our patients. And here you can see the ADAPT study found that CAM-APS FX system significantly improved maternal glycemic control in pregnant women with type 1 diabetes compared to standard insulin therapy. Practitioners using AD systems spend an additional 2.5 hours per day in the target glucose range, achieved a better control of hypoglycemia and more time in range overnight. A significant increase in time in range for 10.5%. I think this is really a lot. Here in Austria, when a woman get pregnant, or before a woman get pregnant and she wants to change up to a pump, we recommend this CAM-APS FX. The Crystal study found that many Medtronic 780G system improved overnight glycemic control, reduced hypoglycemia, and increased treatment satisfaction in pregnant women with type 1 diabetes compared to standard therapy. While overnight time in range wasn't significantly different, the overall time in range, sorry, but the overnight results showed significantly improvements. The trial noted positive trends for pregnant outcomes. And why do we need fully closed loop systems in type 1 diabetes? And the answer is to reduce the massive burden of diabetes type 1. Open label, single center, randomized 2-period crossover design study with CAM-APS HX, fully closed loop. It runs a Cambridge adaptive algorithm to automatically adjust insulin delivery based on real-time sensor data without requiring mealtime input from the user. And the system learns and adapts over time. And as you can see here, there are 3 additional hours each day with glucose in target drain. This is very good, but I think the most important thing is that there is, and here you can see, a massive positive change in life. It's largely due to the reduction of mental and emotional burden. And my colleague Kadiyala, she showed us at type 1 diabetes patient that there is an enormous burden to count carbs, and when you are not when it's not necessary to put in carb ratios or carbs into the pump, they enjoyed it, and the burden is not here anymore. This is also very interesting. This CAMA-PS algorithm was also tested for people with type 2 diabetes. There was a study with 26 adults, and you can see this that also here you have an increase of time in range, a decrease in time in hypoglycemia, and also a decrease in HbA1c. And there were 8 additional hours each day with glucose in time in range, the target. And the last thing I would like to represent is this one. It's a study which was placed during the COVID pandemic. The pandemic created a need to reduce frequent fingerstick tests, which minimize contact between nurses and patients. The study found that CGM with Dexcom G6 was able to detect rapid changes in trends glucose level more quickly than traditional hourly finger sticks. The study suggests that CGM is feasible and accurate method for managing DKA in hospital settings. So I think this is very interesting, and so we can trust the results of the CGM. And finally, I would like to thank everybody involved in the Congress, for researchers, also clinicians, and also patients who work toward the same goal to treating diabetes and hopefully curing this disease in the future.
Thank you very much, Marlies, for sharing your personal EASD annual meeting highlight with us. And to everyone, stay tuned for the next release of our Best of EASD 2025 series, hosted by the EASD Early Career Academy. Thank you.
Thank you very much.